Hello. Welcome. Thank you for joining us this afternoon. Give it a few moments for folks to join. All right. Welcome to our Baptist Behavioral Health Grand Rounds. Thank you for joining us. My name is Dr. Francesca Varello-Sims. I'm the Director of Education and Training for Baptist Health. Before we begin, just a few notes on today's presentation. If you have any questions, please submit them into the chat or the Q&A box, and I'll be moderating that throughout, and we'll hopefully have some time at the end to get those answered for you, okay? If you are calling in from a mobile device that is not connected to a Zoom account with your name, please go ahead and sign into the chat with your first, last name, and license credentials for credit granting purposes. At this time, I'd like to introduce my colleague, Haley Mahler, from the National Alliance for Eating Disorders. Haley?
Thank you so much, Dr. Sims. Hi, everyone. My name is Haley Moeller. I am the Education Coordinator at the National Alliance for Eating Disorders, and we are just so thankful to be a part of today's event. The Alliance is the leading national nonprofit organization dedicated to outreach, education, early intervention, support, and advocacy for all eating disorders. We currently have 6 virtual therapist-led support groups, including 3 pro-recovery groups for individuals recovering from eating disorders, an LGBTQ+ pro-recovery group, and groups for friends and families of loved ones experiencing an eating disorder. We also provide support, education, and referrals for all levels of care through our toll-free helpline, as well as through findedhelp.com, which is the largest free national database for eating disorder clinicians and treatment programs. Thank you all again so much for letting us and Equip, which is one of our partner organizations that Dr. Zucker works for, be a part of this event. We are so excited. And with that, I am going to turn it back to you, Dr. Sims.
Thank you, Haley. At this time, I'd like to welcome our speaker, Dr. Zucker. Dr. Michelle Zucker is board certified in both pediatrics and adolescent medicine and serves as the Regional Medical Director of Equip. Dr. Zucker graduated from the Rosalind Franklin University of Medicine and Science. She completed residency training in pediatrics at Rush University Medical Center in Chicago and an adolescent medicine fellowship at West Virginia School of Medicine. Prior to joining Equip Health, Dr. Zucker was an assistant professor of adolescent medicine at the Parolin School of Medicine at the University of Pennsylvania and the Children's Hospital of Philadelphia. There, she cared for patients with eating disorders in the inpatient and outpatient settings. Her primary clinical interests include eating disorders and reproductive health. Welcome, Dr. Zucker.
Thank you, Dr. Sims. So today I'm going to talk about what every medical provider should know about eating disorders, but probably didn't learn in school. I have no disclosures. So by the end of this course, learners will be able to describe 3 common myths and about eating disorders and the importance of early identification and treatment of eating disorders. Learners will be able to discuss the hibernation response of malnutrition and its impact on patient vital signs. I'm going to change that. We're actually going to talk more about low energy availability and its effect on patient vital signs and other signs and symptoms of eating disorders. The hibernation response is going to be part of that. At the end of the course, learners will be able to perform an initial medical visit and evaluation for a patient with a suspected eating disorder, and identify, screen, and refer patients with eating disorders to evidence-based treatment. Why is there a big to-do about eating disorders? Eating disorders affect at least 5 million Americans every year. That's new diagnoses. So additively, that's millions upon millions of people in America who actually have eating disorders. The rates of eating disorders have at least doubled during COVID-19, the pandemic, with hospital admissions doubling or even tripling in some settings. There are a number of reasons that this may be, including isolation from other people, the lack of ability to burn off energy, and the fear of eating too much to gain weight because you're not burning off that energy, fears of resource use. People may feel guilty to eat the food that they can obtain because they may feel that other people deserve it more. And then there's a 4 to 5% mortality associated with eating disorders, as eating disorders are the second deadliest mental illness following opioid addiction. A few years ago, eating disorders was the first deadliest mental illness. So why are eating disorders deadly? Suicide is one reason. 1 in 5 deaths in patients with anorexia nervosa are related to suicide. There's refeeding syndrome, which we'll talk about later. That's a metabolic derangement, which can have dire consequences on nearly every organ system in the body. Fatal arrhythmias can occur related to low heart rates, abnormal electrolytes, and some other conditions that we'll discuss. And they may have heart failure or other major organ failure. So one of the things that also contributes to the high rates of eating disorders is the pro-eating disorder culture. There are pro-anorexia sites, pro-bulimia sites, and social media exposure everywhere. A lot of it is couched as health, being healthful. Do this diet and it'll treat your PCOS. Do this diet and it will help treat your diabetes. Do this diet and it will get rid of your risks of anything. There's a lot of money that people make by selling diet culture on the internet and on social media. And it's highly influential. Males are not immune. For a very long time, we didn't realize that males could develop the same eating disorders as females. It may have been looked at as the need to be very athletic and how to maintain that through diet, exercise, and muscle building. We also know now that there are men who become kind of addicted to muscle building, and that's a different type of eating disorder. To accommodate for the fact that we have learned that men can have eating disorders, the DSM actually changed the diagnostic criteria for anorexia nervosa to remove the requirement that someone lose their periods for a diagnosis to be made. That also allows diagnosis of eating disorders not only in people who do not have a uterus, but also people who may be prepubertal or on suppression of menses for any other reasons. As I already mentioned, diet culture is pervasive. It is everywhere we look. It is on many, many advertisements on television, on Facebook. It's all over TikTok, and it's almost inescapable. So I already mentioned that males can develop eating disorders, but who else develops eating disorders? Well, we know girls do. Guys do. It was originally thought that thin, white, upper middle class teenage girls and young adult women were the most likely people to develop eating disorders. And therefore, they were the most likely to have their eating disorders identified and treated. But we now know that eating disorders can affect all ages, genders, ethnicities, socioeconomic classes, body shapes, and sizes. Because of the lack of recognition by many that so many can be affected by eating disorders, only about 20% of people with eating disorders actually receive any treatment, and much fewer will receive evidence-based treatment. So it's important to keep in mind that anybody can develop an eating disorder. So there are a lot of myths about eating disorders. People think that eating disorders are a choice or a phase and figure that someone's going to grow out of it. People think that eating disorders are someone's fault. It was a parent's fault or a bully's fault, or the patient did it intentionally. Another myth is that you can't tell if someone has an eating disorder just by looking at them. Sorry, that you can tell that someone has an eating disorder just by looking for them, but that's a myth. The truth is you can't tell if someone has an eating disorder just by looking at them. People with eating disorders can have normal weights and BMIs, low weights and BMIs, or high weights and BMIs. And there's also a lot of thought that people cannot recover from eating disorders, and that is absolutely a myth. There can be full recovery with proper treatment. We also know that eating disorders are brain disorders, which are impacted by many factors. There are genetic factors, such as people having eating disorders in their families, or other family members with anxiety, depression, substance use, gambling. But not everybody with an eating disorder has that family history, and not everybody with that family history has people that develop eating disorders. So we also know that there are environmental influences on development of eating disorders, such as lack of adequate food, changes biochemical processes in the body and starts to trigger changes that lead to decrease in appetite and all the physical signs and symptoms associated with the eating disorders. And then we know that, like I said, biological triggers, when people don't have enough nutrition, they can just get stuck. So most people are familiar with anorexia and bulimia, but there are many other eating disorder diagnoses that we may see. Anorexia nervosa is probably the most common that you hear about, but bulimia nervosa or binge eating disorder are probably more common than anorexia nervosa. Avoidant restrictive food intake disorder or feeding intake disorder, or ARFID, is a feeding disorder that is becoming more commonly identified and treated. Those are the kids that are the picky eaters and either run into medical trouble when they're picky eating and becomes more restrictive and leads to malnutrition that can be severe enough to require hospitalization to manage. We also identify and treat ARFID when kids are so picky that it starts to impact their social functioning. They can no longer eat around other people or what other people may be eating, or even what they ate the day or the week before. So it becomes disruptive not only to them, but their ability to interact with others around them in age-appropriate ways. There's other specified feeding or eating disorder, which doesn't quite fit with any of these categories, but may also include atypical anorexia, which is basically anorexia in someone who is still of normal weight or high weight. So not everybody with anorexia is severely underweight. And it's important to remember that, because people who are normal or overweight can still develop all of the medical complications of people who also are very much underweight. And eating disorders rarely occur in isolation. Many patients will also struggle with anxiety, depression, substance use, or trauma. So anorexia, as we said, it's the one we hear about the most, but it's not necessarily the most common. And the average onset is 13 to 15 years. However, I have seen anorexia diagnosed and treated in patients as young as 6. Bulimia nervosa, prevalence is about 1 to 3%. Onset is 16 to 17 years, average, but again, can happen much earlier. Binge eating disorder is about 3%, and that onset is later. And then ARFID, which is becoming more and more common. It's more common in males, and the onset is 8 to 12 years on average. And I have seen patients as young as 3 or 4 be treated for ARFID. So eating disorders can really occur at just about any age. We see them in adults, either as a new presentation or lingering from when they were younger. And we also see them in young people. So we see them in young people, old people, people in the middle of their lifespan. We see people who have had eating disorders for many years and have not had treatment as well. Those may be enduring cases that require a lot of assistance to decrease the behaviors associated with the eating disorder. So how do eating disorders present? Eating disorders can present in a lot of different ways. There may be some signs and patterns in the patient's history that you may notice, changes in food intake and behavior, things like skipping breakfast, no longer bringing lunch to school, but not purchasing lunch. Some parents can track that with a card or a system that they can check, saying that they're not hungry for dinner because they already snacked or ate. They're not hungry, so they don't need food. Lots of reasons that the kids or the young adults suddenly come up with to not be eating as they used to. Some may over-exercise or compulsively exercise. This can include kids who are in organized sports who may add additional exercise or practice that is not required by their coach to participate on the team. Or this may be kids who don't participate in organized sports, but incessantly are moving around the house or going on runs or playing basketball and get very upset when they're told they need to decrease those activities or stop them. A lot of the time, people with eating disorders may have personality traits like perfectionism or overachievement. And so they kind of get stuck in these loops where they keep doing things until they perfect them. And that includes avoiding eating at some times and compulsively exercising. And then there may be noticeable weight changes. A parent or a physician or a family friend, often it's a family friend, may notice that all of a sudden it looks like the young adult or the teenager or the child look thinner. Often it's a friend of the family who hasn't seen them in a while and says, wow, they really lost a lot of weight, when the family has barely noticed it because they see them every day. And then not everyone presents with classic restriction or purging or exercise that we can see as behaviors of the eating disorder. Those are things we commonly think about. Often they have somatic complaints, and we'll go through those in a couple of minutes. They may have failure to gain weight and not weight loss. And they may not have any overt signs or symptoms at all. So patients with binging and purging, for instance, may maintain normal weights and not lose weight, or maintain normal growth and development, even in the face of a very severe eating disorder. So as I mentioned, clues to look for. When I see a patient, either that I'm evaluating for an eating disorder or I'm seeing in the primary care realm, I look at their chart and I say, all right, where are they on their growth chart? Have they maintained their growth trajectory over the years, or has it changed? Did they have a sudden drop and now pick up again on a different trajectory? Have they flatlined, or has it just continued to go down? So you can glean a lot just by looking at the growth charts. And I look at weight and height to see if height has continued to go up, but weight has not, or weight has gone down, which will then affect the BMI. So patients who grow taller but do not gain the weight or maintain the weight gain, so either stagnate or lose weight, while they're growing taller will drop their BMIs. So you can drop your BMI without even losing weight. And then I look at their vital signs. Are they bradycardic? Anybody with a heart rate under 60 by definition is bradycardic. Anyone with a heart rate under 50 really piques my interest, really makes me worry that there may be an energy imbalance. I look for hypotension, if their blood pressures are suddenly much lower than they were before, or if they have orthostatic changes, they may complain of dizziness, and I may check to see if they're orthostatic, and they are, or their temperatures are lower than they typically run. Those are all clues that there might be something going on in the realm of an eating disorder. On physical exam, you may see things like acrocyanosis. Parents often will say, my kid's fingers turn blue, their hands turn blue, their toes turn blue, and we warm them up and they get better. Well, just like newborns, people with eating disorders and malnutrition can have acrocyanosis. They get hypercarotenoemia. A lot of these folks may eat a lot of sweet potatoes and carrots and orange foods, which increase the orange colored pigment in their skin. They may have eroded tooth enamel from purging, from vomiting, which is one of the behaviors of eating disorders. Some people have erosion sooner than others. Some can be purging in that way for years and not have much damage, and others may do it for a short amount of time and have a significant amount of damage. So it's hard to tell just from a tooth exam if someone's actually purging or not. There may be parotid gland enlargement associated with purging, which may even enlarge a little bit more before it resolves when someone stops purging. There may be hair loss or dry, brittle hair or dry skin in general. You may see lanugo or an increase in hair growth over the entire body. It can happen on the face, the arms, the back, the chest, the legs, the stomach, everywhere. So it's important to think about, is it lanugo or is it something else? Could it be something like hyperandrogenism? So there could be other things that could cause that too. And then there's Russell sign, which is a scarring of the knuckles on patients who use their fingers to cause purging from the acid that comes up when they vomit. So sometimes I do an EKG if the heart rate is much lower than it's been, and certainly if it's below 50, to confirm if the patient is actually bradycardic or not. And I worry that, because I know that even in elite athletes, most healthy teenagers have heart rates that are over 50 or over 60. And then prolonged QT is something else that you can see. You can see it associated with purging, electrolyte derangement, so abnormal electrolytes. And it's something that I am concerned about when I see this. I have to think about, is it something that they've had their whole life and I just have never gotten an EKG before? Are they taking a medication or having electrolyte derangement that I have to look into as a cause? And most often these patients are symptomatic, but these arrhythmias can be fatal. And they're at higher risk of developing torsade de Pointes when they have prolonged QTC. So earlier I mentioned low energy availability, and I'm going to talk about that along with relative energy deficiency in sports, which are kind of newer terms, only the last, 5 years or so maybe, to describe a condition where there's insufficient energy intake to support daily exercise, energy expenditure, resulting in a low energy availability, or LEA, and inability to support the physiologic functions necessary to maintain optimal health and performance. And this is exactly what we see in many of our patients with restrictive eating disorders. They may present with fatigue, weakness, or malaise. They may present with missed periods, menstrual irregularity, or even low libido associated with the malnutrition, the lack of energy availability, and the physiologic changes that result in the body. They may complain of dizziness, pre-syncope, or syncope. They may have frequent illnesses or recurrent infections. They may have, like I said, hair loss, dry skin, or even pressure wounds if they are malnourished enough and leaning on bony prominences. We often see this in kids who are doing sit-ups, who are severely malnourished and don't have a lot of fat tissue or muscle tissue left over their spine to kind of pad them, and they develop pressure wounds. As I mentioned, sometimes kids stop growing. They don't gain weight. They may not grow taller. So you may have pubertal delay. You may have pubertal arrest. And therefore, you can have primary amenorrhea, where the menses are delayed because you either don't go through puberty or puberty stops, or secondary amenorrhea, which occurs after menses have started, but the body has changes that make them stop. And we'll go over that in a moment. So these kids and young adults may have trouble staying warm. They may have acrocyanosis, as I mentioned. They may have mood changes, a lot of mood changes. Decreased muscle strength and endurance is another sign. These are kids that often actually say, like, I am at the peak of my fitness because I've lost all this weight and I'm so muscular now, and I cannot possibly actually have decreased muscle strength or endurance. I am better than I ever was before. And the reality is that as they lose fat, you see more defined muscle, but then they also start to lose muscle as they continue to lose weight. And I've had many patients who felt that they were at the peak of their performance at their lowest weight, who later recognized upon renourishment and getting back on track with where they were before they lost weight, that they had much better performance, that other people were recognizing that their athletic performance improved, or that their strength has now improved. They have impaired judgment. When people don't have enough energy availability, they may not even realize that it's a problem, that some people have anosognosia, which is a kind of a classic sign of malnutrition and eating disorders. They're unaware that it's really a serious problem, that they can have their primary care physician, their specialists all telling them that they need to start eating more, stop losing weight, and they don't follow the advice because they don't recognize it as being a problem. Because of the decreased muscle strength, they're at higher risk of sports injuries because of changes that occur in bone metabolism. They're more at risk of stress fractures and fractures. And then these patients very commonly present with the female athlete triad. And that's kind of been incorporated into RED-S, and is low energy availability plus menstrual irregularity plus low bone mineral density or bone mineral density changes. Whereas we used to talk about the female athlete triad as disordered eating plus irregular menses or lack of menses and decreased bone mineral density. So we've changed the definitions a little bit in more recent years to reflect the increase in understanding that we have about why these things take place when people become very malnourished. So longer term, when people have become malnourished and remain in a malnourished state for a significant amount of time, we've now learned that there are a lot of physiologic changes in the body that occur and contribute to many of the symptoms that we see or the complaints that the patients have. So there's a decrease in insulin, a decrease in leptin, a decrease in IGF-1, a decrease in osteoclastin, LH, FSH, estrogen, testosterone, TSH, T3, and free T4. So all of those can be decreased. You can have increase in cortisol, which actually contributes to low heart rates as well. Growth hormone, PYY, and ghrelin. There's a lot of research about ghrelin and how that contributes to hunger and satiety cues and contributes to development of eating disorders and maintenance of eating disorders. We may see dyslipidemia in these patients, as well as hepatic dysfunction. We do see low resting metabolic rates, as I mentioned, and this is where the sleeping bear comes in, that when a bear goes into hibernation, all of the systems slow down. They don't move much. They digest slower. They don't have hunger cues, so they don't get up to move around and get food. To conserve energy, their heart rates slow down, their guts slow down, their temperature drops. So we see all the same changes in our patients with severe malnutrition related to their eating disorders. They may have delayed gastric emptying. That delayed gastric emptying may be so bad that it's become gastroparesis, and they may have elevated transaminases. As I mentioned, you can see hypotension, bradycardia, orthostasis, arrhythmias. You can also see pericardial effusions in these patients, and even heart failure develop. They can have kidney dysfunction and abnormal electrolytes related to the kidney dysfunction, intake, fluid shifts, etc. There can be immunological changes and bone marrow suppression. I once had a patient who was admitted to the hospital with a hemoglobin of about 5, and she was very much symptomatic. And during the course of the admission, we learned that she had a very long-standing eating disorder and had continued to lose weight for a very long time. It was only recently noted that she had anemia because it hadn't been checked before, and because she fainted. So bone marrow suppression is quite common, maybe not that severe, but every cell line can be affected. That you can see low platelets, low white blood cells, and red blood cells affected. And I've also actually had patients who were transferred to my care who had a bone marrow biopsy before they felt comfortable that there might be another etiology for multiple cell lines being affected at once. Studies have shown that there can be gray matter changes that may or may not be reversible when someone is refed. And as I mentioned, decreased bone mineral density, osteopenia, and osteoporosis. So I mentioned that there are mood changes, a lot of mood changes. Depressed mood, anxiety, social isolation, sleep disturbance, anhedonia, poor concentration, cognitive rigidity, obsessions and compulsions, personality changes. I've even seen psychomotor slowing in a few of my patients who swore there was no problem with how they were acting. They couldn't understand why I was worried. And when they were later refed, they looked at some videos of themselves in that prior malnourished state and said, wow, I can't believe how different I looked and sounded, that I didn't sound coherent. So it can be that severe. And it's kind of a conundrum because many psychiatric symptoms can be triggered by malnutrition in patients who have never had those psychiatric symptoms before. And then malnutrition can exacerbate pre-existing psychiatric symptoms. So one of the things in the course of treatment of eating disorders is to decide when to add medical management of those symptoms. And most people will agree that because malnutrition can exacerbate mood disorders and cause mood disorders, or at least mood disorder symptoms, that until the patient is closer to 80% of the weight needed to get back on track with growth and development or their prior healthy weight, that we wait until closer to that point to even think about treating these, because the body will not likely respond. It's still too malnourished. So I mentioned bone health, and this is also a very big topic and a very hot topic. We know that genetics play a part in decreased bone mineral density, osteopenia, and osteoporosis. And then there are modifiable things like adequate calcium and vitamin D. We have kind of a conundrum here too. Weight-bearing exercise is important for maintaining bone health for everyone, whether or not they're malnourished. And we also recommend that patients decrease physical activity in order to improve their energy availability to recover from their eating disorder. So more and more research is being done into ways to incorporate physical activity into eating disorder treatment. Not necessarily participating in sports, but finding other alternative activities that are pleasurable and fulfilling that can help people do a little bit of that weight bearing without using too much energy. And then, as I mentioned, people lose their periods. LH and FSH go down, estrogen goes down, osteoclasts are affected, and so bone health suffers. And we know estrogen is required for bone mineralization. The reason that this is such a hot topic is that bone loss in adolescence may be permanent. That the majority of peak bone mass accumulation is during adolescence and is achieved by the mid-20s. So if someone develops an eating disorder before their mid-20s and either is growth stunted and then maybe has low estrogen and loses bone mass, they often get stuck, as you can see with the dotted and blue line, at a lower bone mineral density for life. And of course, plenty of our patients who have eating disorders may be taking hormonal contraception, which can blur the picture because some of the hormonal contraception makes periods go away. So treatment, evaluation. Well, we can do DEXA scans whenever someone is amenorrheic for about 12 months, 6 to 12 months, 12 months, depending on the source you use. We recommend checking a DEXA scan to look at bone mineral density. And if it's low, then we know we kind of have an urgency to work on this, especially in young people before they have reached peak bone mineral density. So the key and the best medicine for accomplishing that is nutrition, getting back on track with growth and development, gaining back their lost weight, which helps correct the hormonal imbalances that lead to the changes in the bone. And we know that that's happening when there is resumption of regular menstrual cycles or normalization of hormones. So for girls, that's their estrogen, or people with ovaries, it's their estrogen. For people with testes, it's their testosterone. And then we also know that supplementation with estrogen-containing pills, for example, combined birth control pills, which is commonly done in patients who lose their menstrual periods, it does not generally improve bone health and may mask the natural return of menses. So you may not know when your patient actually has improvement related to the nutrition and may prevent them from developing healthy bones again. The way it is managed, if hormones are going to be used, is typically an estrogen patch, continually and cyclic progestin, which is shown to have a slight improvement in bone mineral density in some studies. But the evidence is not robust. So the most robust evidence is about regaining lost weight and having appropriate body fat. So evaluation and management. So in the clinic, you could do a urine dip. We recommend getting blind weights in a gown, standing backwards on the scale in case the patient freaks out because they're afraid of gaining weight. As I mentioned, orthostatic vital signs. It's important to look for sequelae of malnutrition and rule out other reasons for the malnutrition. For sequelae of malnutrition, and other reasons for the malnutrition. So potassium, phosphorus, and magnesium are important to check, as are liver and renal function tests. Think about testing for thyroid function, looking for reasons for amenorrhea, estradiol, LH, FSH, and prolactin. And in males, considering to check testosterone, LH, and FSH, and a vitamin D level. And then additional workup that you may consider, an EKG to look for those arrhythmias, prolonged QTC, other signs of cardiac muscle damage that could be resulting from the malnutrition. Celiac disease, there's a significant percentage of patients who get diagnosed with eating disorders who may also have celiac disease. However, if they have an eating disorder and they have celiac disease, unfortunately, treating the celiac disease does not usually get rid of the eating disorder. So you have to do both. Looking for inflammatory bowel is another potential thing that one may want to do for patients depending on their clinical symptoms and their laboratory findings. Can also think about checking for inflammation if there's any question that another process is going on. And if that is elevated in someone severely malnourished, that's a concern. Usually that's also blunted, and ESRs are quite low in people who are severely malnourished, unless there's another process going on. As I mentioned before, loss of Menses. We also want to make sure if the patient is more than 3 years out from menarche, if they have signs of virilization, hirsutism, we think that it's not lanugo, but it's actually hirsutism, clitoromegaly, refractory acne, that we think about looking for PCOS in addition, and to make sure we rule out pregnancy if someone has lost their periods. And as I mentioned, DEXA scan if there's been prolonged secondary amenorrhea or prolonged arrest of development and low hormones. So people often ask if there's medication to treat eating disorders. There is no FDA approved medication for anorexia or ARFID. There are limited approved options for adults with bulimia nervosa or binge eating disorder. But what we know is food is the best medicine for improving mood changes associated with eating disorders, getting on a regular eating schedule, eating throughout the day, either helps bring back hunger and satiety cues or helps satisfy hunger and satiety cues, which also tends to improve mood as well. Also allows enough serotonin to be made to actually function better. That also gets blunted when you're severely malnourished. And then most kids, one other thing, evidence-based. The evidence base for treating eating disorders lies with behavioral treatments such as family-based treatment. Family-based treatment, which puts the parents in charge of the nutrition and renourishing their child, has the most success of all of the treatment modalities for young people with anorexia nervosa. So most of these patients can be managed in an outpatient setting. If vitals are stable, labs are normal, most eating disorder patients are safe to do this as an outpatient. As I mentioned, FBT is the best evidence-based treatment, and we have evidence that a virtual FBT program can be as effective as an in-person treatment program. We also know that it's a myth that more time spent in care is associated with better outcomes. So patients who spend many weeks and months in residential treatment or PHPs and IOPs don't have any better outcomes than patients in FBT. In fact, sometimes those outcomes are poorer. All right, so FBT, as I mentioned, parents are tasked with renourishing their child in the first phase of treatment. Then, as the patient gains weight, eating disorder behaviors decrease. The child begins to slowly regain independence under observation of the parent. And then in phase 3, the child is eating independently, can focus on shifting to, then we can focus on shifting to normal adolescent concerns. So basically the eating disorder is in remission, and we want to make sure that the patient gets back to living their best adolescent or young adult life. And then only 49% of adolescents with AN achieve full remission with traditional FBT, meaning most families still need more support. So it's good, but it's still not great. So this is a study that was done at Equip where I work. We do virtual eating disorder treatment. And for young people, the first modality that we tend to use is FBT. And you can see that at 16 weeks of treatment, 80% of patients achieved target weight gain. Depression and anxiety symptoms were improved. Eating disorder symptoms were reduced. And caregiver burden decreased and their confidence increased. So as the treatment was successful and their kids gained the weight, it became easier and they became more confident that it could be done. So I mentioned earlier that eating disorders are deadly, but we also just discussed that they are treatable. Early identification and referral are key. And evidence-based treatment leads to higher chances of recovery. We also know that early response to treatment is key from many studies, and greater than 4 pounds of weight gain in 4 weeks is associated with a higher rate of recovery. And then a higher level of care may be needed when there's medical instability or when there's inadequate supervision at home to keep a patient safe, either from a medical or a psychiatric standpoint, or the carer is unwilling or unable to do FBT or safely keep the patient at home. We always try and keep the patient at home when possible, because home is always the best place for a young person to be, unless it's unsafe. So as I mentioned, sometimes we refer to inpatient for management. Reasons for medical stabilization and an inpatient hospital bed: unstable vital signs, electrolytes that are dangerously low, which may indicate impending or active refeeding, which the risk is high when people lose a significant amount of weight in a short amount of time. And as I mentioned earlier, people in larger bodies with rapid weight loss can have the same medical complications as people with smaller bodies and lower BMIs, given the same amount of weight loss over the same period of time. Or at least the same degree of weight loss, the same percentage of weight loss over the same amount of time. So medical instability, bradycardia, as I mentioned, electrolyte abnormalities, prolonged QTC or other arrhythmias, low blood pressures, orthostasis, especially symptomatic orthostasis. It is less likely that your patient will be admitted purely for orthostasis without symptoms, and then severe malnutrition or less than 75% of median BMI. Again, I mentioned this can happen at any weight range or any BMI range. Okay, so I've mentioned refeeding syndrome a couple of times and electrolyte derangements. So I'm going to try and get through this. I think we can. The most feared and fatal medical complication of eating disorders is perhaps refeeding syndrome. Unfortunately, most of the studies we have about refeeding syndrome are in patients who have been hospitalized. It's not from outpatient data. For the most part, there was one large study, fairly large study, that was done during World War II, where volunteers were actually put through an experiment. The first part of the experiment, they were given a pretty good amount of calories and did a certain amount of activity, and all of their bodily functions and their mood and their vitals, like their vitals, their chemistries, their moods, all that was evaluated. And then the calories were about cut in half, but they still did the same amount of activity, whether that was walking, attending school, exercise. And again, it was monitored, their electrolytes, their vital signs, their other chemistries, their mood. And then the third phase was refeeding, where they were again allowed to eat the same amount of food as they were before. That was what was provided. And it was found that even in patients who had no prior eating disorder history, many of them developed the same signs and symptoms and biochemical abnormalities. Then it was mostly their electrolytes that they were monitoring, but as are patients with eating disorders today. So we know that eating disorders are not intentional and can happen even when other things other than a desire to lose weight are the trigger. Typically, refeeding syndrome is seen in the first week of nutritional rehabilitation, often within the first 72 hours of initiation of that nutritional rehabilitation. We also know, sorry. Nutrition that's being given with the refeeding but not more often. So when I was in training for a very long time, the mantra of treating eating disorders was start low, go slow. And we saw refeeding syndrome closer to 7 to 10 days. Now, when we're starting close to 2,000 calories instead of maybe 500 or 700 calories, we're seeing it between 3 and 5 days typically. So not more often, but sooner. So based on that, the recommendation, the standard of care is to check electrolytes, including magnesium, phosphorus, and potassium, which are the primary electrolytes that change in refeeding syndrome on a daily basis. All right, so as I mentioned, refeeding syndrome. This is kind of the secret behind it. So people become starved for whatever reason. They have an eating disorder, they have a GI problem, they have chemotherapy that's caused vomiting, they're post-op and can't eat, whatever the trigger is, their energy availability drops, they become starved. And then just from that alone, from inadequate intake, they may have depletion of electrolytes. And then when we start to refeed, they may have an increase in calories and an increase in glucose load that wasn't there before. Well, with increased glucose load, we have increase in insulin release. And that insulin release is actually what causes the intracellular movement of phosphorus and potassium. We're not 100% sure why the magnesium does it, but it does cause the phosphorus and potassium to move into cells and therefore be at a lower level in the blood. Thiamine is also used more rapidly at this time, which increases the risk of Wernicke-Korsakoff, which is why often you may see that supplemented for patients in the hospital as well. You also get increased fluid volume related to changes in angiotensin and renin. That may lead to the low phosphorus, magnesium, and potassium, which is essentially refeeding syndrome. Phosphorus is the most commonly affected electrolyte. And why do we care about that? Well, it can be really dangerous. People can die from this if it's left unchecked and untreated. So the heart, so when there's hypophosphatemia, the heart doesn't function properly, and this can lead to heart failure or arrhythmias. You can have respiratory failure because the diaphragm doesn't function correctly, neurological dysfunction, peripheral nervous system problems, muscle damage, hematologic functions may be impaired or become impaired, may have eye problems and GI problems. So who's at highest risk of developing refeeding syndrome? So those with severe malnutrition, like very severe malnutrition, probably less than 70% of median BMI, or a BMI somewhere in the 15 range-ish, depending on the age, sometimes less. Magnitude of weight loss. So there are criteria that can be used. One of them is Aspen. And in Aspen, a 7.5 to 10% loss of weight over time between 2 points can indicate an increased risk of refeeding syndrome. And then significant amounts of weight loss in a month, in a year, like in a month, 3 months, 6 months, and in a year can also lead to increased risk of refeeding syndrome in and of themselves. Also, patients who are electrolyte depleted before the start of refeeding are at higher risk of developing complications of hypophosphatemia, low magnesium or low potassium when those stores are further depleted by movement into the cells. And as you mentioned, we know that higher calorie feeding does not increase rates of refeeding syndrome. So there's not a lot of consensus on how to prevent this, either in the hospital or in the outpatient world. There have been a couple of studies done on hospitalized patients, but none really in outpatient. But it's promising. There's a retrospective study of 70 hospitalized adolescents in Canada with an average median BMI of 83%. They were all supplemented with oral phosphate given under supervision and continual electrolyte monitoring with a refeeding protocol that started at 1,800 calories a day, and they saw 0 cases of refeeding syndrome. So, of course, more studies are needed on how to identify those at moderate to high risk of development of refeeding syndrome and how to best manage that in an outpatient setting. I'm hoping that there will be more studies on exactly this about supplementing in the outpatient setting to prevent the need for hospitalization. We're not quite there yet. Okay. All right, so take-home points. Eating disorders are common, can affect anyone, including those at mid-range or high BMI, can be deadly and are not a choice. Low energy availability can affect nearly every organ system, and low heart rates in anyone in the context of weight loss is not healthy. As I mentioned, that the increase in cortisol, the decrease in energy available decreases that heart rate. And anyone who is not growing well is not healthy. An evaluation to look for sequelae of malnutrition or other causes of weight loss is appropriate even in a pediatrician's office, and early recognition and treatment is key. Primary specialists, don't be afraid to encourage increased nutrition and limited activity to help improve that limited energy availability. Okay.
Thank you, Dr. Zucker. All right, so we will move into the question portion for the remaining few minutes here. So we have one from a peds onc nurse. We see this sometimes with our patients on tube feeds. Just curious, is it more or less common with enteral feeds versus eating by mouth?
Oh, that's a great question. So it depends. It is possible to better control the ratio of carbohydrates and fats and proteins when you feed by NG tube, but we still see it occur when people are NG fed or G tube fed, and they've been significantly malnourished. So it's not an absolute preventive measure to do that balancing.
And then, you spoke about the family style of therapy. Do you have thoughts around, some of the aspects that go into why it's not 100%? I mean, nothing is always right, 100%, but what are some of potentially the considerations you've seen, family dynamics, what might go into that?
Sure. I think one of the most common things I see is that families may stop short of full weight restoration. So they don't actually get their kids back on track with growth and development. So that leads to a state that is basically where they're growing below where they used to. And that discrepancy, the higher that discrepancy is between where they grew and where they're growing now, the higher the chance that they will relapse or maintain their eating disorder, that they seem to be better, but under the surface, they may not be fully recovered. So that's one factor. Another factor is that the family may just need another mode of treatment, that FBT isn't for everyone. That either the parent may not feel empowered, despite support, to be able to put the plan in place to take over the nutrition and make sure that their child gets adequate supervision to get the nutrition in and not over-exercise and have those eating disorder behaviors. That's just inherent in some parents, that they can't get over that hump, or they've had their own eating disorders that prevent them from fully being able to enforce the recommended protocols because they're still a little uncomfortable with them themselves, or they may not recognize that it's a problem. So sometimes we have to put it in the hands of the young adult or the teenager to see if they can instead kind of get out of that slump that they're in.
Right. Yeah, it's tough because you think about it, who's buying the groceries, and preparing the meals. And so it does make sense that it would need to, you'd have to have that familial component. But if there's disordered or like a non-compliance factor, that's an uphill battle. So one final question for you before we reach the 1 o'clock hour. We have from Ms. Duran, as a chaplain, I'm wondering if there are any common spiritual issues that impact eating disorders and the recovery process.
Oh, yes. Well, there's some spiritual, probably more religious, that many religions focus around food. Judaism, Muslim, we hear again and again that the focus on food, the pressure to eat in front of other people, the incorporation of periods of fasting in the practice of the religion can all certainly not necessarily trigger an eating disorder, but certainly complicate treatment and recovery when they prevent the patient from getting the nutrition that they need, even for that short period of time.
Yeah, that makes sense. It also, makes me think about other activities where weight is very apparent in their lives and they're conscious about it, like sports, you know what I mean, or dance, whatever it might be. So that's a similar situation. Yeah. Well, thank you so much for your time this afternoon. We really appreciate it. If anyone has questions related to credits or anything like that, please email the one that's placed into the chat, behavioralhealtheducation@bmcjax.com. And again, thank you to the National Alliance of Eating Disorders and Dr. Zucker today for their wonderful talk. I hope everyone has a good afternoon. Thank you, Dr. Zucker. Have a good one. Bye-bye.